Welcome to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. With Innovaccer, everyone works in the service of patients like never before as one. Visit us online at innovaccer.com.
Hello, everybody, and welcome to the Innovation Accelerator podcast. I'm David Nace, Chief Medical Officer here at Innovaccer, and I'm here with several of my colleagues, all of whom are members of our team, Innovaccer's Office of the Chief Medical Officer. Today, we'll be talking about a variety of healthcare industry topics that have been making headlines, as well as what we've been hearing from and discussing with our customers, our partners, our colleagues, and many other folks in the industry. But before we get started, let's go around today's virtual roundtable and have everybody just share an introduction and something interesting or pertinent about yourself and your background to the podcast at hand. So with that, let's start off with you, Dr. Anil Jain. Tell us about yourself.
Great, yeah. So I'm Anil Jain. Joined Innovaccer several months back as the Chief Innovation Officer, focused on our provider transformation work that we do with our clients. And have a long career in health IT at a very large health system, at a very small startup, at a big public company, and now at a incredibly fast-growing organization as well. I would say that what's interesting is that I was an engineer first, which means that I'm constantly looking for ways to re-engineer the way that we do things in healthcare and not accept what I think a lot of us have accepted as sort of the way that we should do things, and just always reinventing the processes. So I would say an engineer first and a doctor second, but it's always patients first.
That's great to hear. Well, we have doctors and engineers on the call, so let's turn it next to Mike Sutten, who happens to be at the CHIME conference in San Diego today.
I am at CHIME, David. Thank you. Yeah, it's like fishing in a barrel. These are all of our primary customers. All the many CIOs, CTOs, analytics folks, in the healthcare space. So it's really a pretty great forum to be at. And unlike Anil, though, I never grew up from engineering, so I still play an engineer on a pretty normal basis. I was, many of you know, I was Chief Technology Officer at Kaiser Permanente before joining Innovaccer, which I just incidentally had my second year anniversary, and been a blast every moment being here.
And you have to tell the most important and exciting, interesting tidbit about your professional career.
Oh, that I was at the CIA for 15 years. We were using data to chase terrorists. Now we use data to help cure patients.
That sounds like the right career move to make. So thanks, Mike.
Yeah.
So next we have Shobha Phansalkar. And Shobha, tell us a little bit about yourself.
Absolutely. And perhaps what distinguishes me from this group, David, is you said there are doctors and engineers here. And I am neither. I am an informaticist with a background in pharmacy. I do have a PhD in medical informatics. So perhaps in that way, I'm a doctor. And my career in informatics and in healthcare IT has spanned both academia as well as the industry. I have primarily worked in clinical decision support, understanding how we can make EHRs better to serve the need of providing better patient care. And that's what brought me to Innovaccer about 9 months back. I lead the informatics efforts here and also the health outcomes team.
Great, and welcome. And then last, I'd like to turn it over to Dr. Paul Grundy. Dr. Grundy, tell us a little bit about yourself.
We may not have enough time to go through Paul's illustrious history. In fact, I just met Bill Wilson here, who was talking about all the State Department stories he told you when he was at IBM with you, Paul. He's at Stanford Pediatrics now.
Well, Paul Grundy, I've spent a 45-year career trying to drive change in healthcare. And along that way, I worked in senior roles in government, in public sector for a large corporation with folks like Anil at IBM, and then most exciting and recently at Innovaccer. And along that way in the journey, I started a not-for-profit, the Primary Care Collaborative, which led the medical home movement. And so I got dubbed the godfather of PCMH. And I'm really excited to explain all that, and you're going to have to come to a later podcast to hear the explanation of how that title occurred. But I look at life through the three legs of the stool. It's the cultural transformation away from an episode of care to managing a population, and authored some books on that topic. It's the payment change. There's only one way to herd a cat, and that's to move the food. And so have worked in policy and government to drive payment change. And lastly, it's the technology that allows a patient to have a plan for them with the data necessary to actuate that plan within their care delivery team and to them as a person. And that's been a very difficult journey. And the reason that I joined Innovaccer was because Innovaccer was further down that road than anybody I've seen. And I was so excited to beginning to see that information is doing for the doctor's minds and the patient's minds what X-ray has done for their vision, right? It's really created a clear picture of what you need to do for the patient and what the patient needs to do for themselves. So delighted to be part of this podcast.
Awesome, and delighted to have you here. And Paul, you've been a beacon of direction for many of us over the years, and a great friend and partner, I think, all well.
And
so
Brian is with us as well, and he needs to come off mute, but would love to hear a bit.
I see he's joined, Dr. Silverstein.
Absolutely honored to be part of the team and the podcast. I'm the Chief Population Health Officer at Innovaccer, just really passionate about being able to deliver better care and do it at a lower cost so it works for the physicians, the patients, and all involved. And I think that one of the fundamental issues is there's a lack of transparency and information, and excited to be part of the cause to fix it.
Great to have you here. So, part of this new podcast series is to kind of update our listeners on what's going on in healthcare in the news today. All of you are keeping abreast of that. And, Mike, for example, is at a conference right now. And Brian, I know you're transporting to New York City to interact with some healthcare leaders. Let me ask each of you a question. So I was interviewed by a news reporter this morning. And the question I was asked was, we've been talking about this movement to value-based care, patient-centered care for some time. Most of us haven't experienced it. When's it going to happen? So with that, let's start off with you. Mike Sutten, I'm going to start off with the engineer in the crowd. I want to hear your point.
Boy, I wish you wouldn't have started with me. But so, as you know, I've only been in the healthcare space for 8 years. I've been doing data engineering, building systems for 40, and never in an industry ever has every single person knows what needs to be done. It's not a vision problem. I think the industry really knows what needs to be done. It's how do you take that first step, and where do you get started? And I think that's what's been fabulous about a lot of our approach is we have a product. We're not saying let's get together and write a spec for what we're going to do. Let's not create a vision what we're going to do. Is we have a product that, as you all know, can be implemented in weeks or months and not years. And almost everything else I've seen in healthcare, it starts at 18 months and moves out from there. And so the fabulous foundation we have with the data activation platform, with those 300 ingesters or whatever the accurate number is, and then with a lot of very useful pre-built capabilities to help drive value, this can all be started very quickly. So in a lot of cases, I know when I'm talking to customers, it's almost like, here's how you get started. And I'll finish with one last thought, because at Kaiser Permanente, I said, because I love this business, I said, we're going to build our own. That was 5 years ago, and they still don't have a data model. They're still debating it. They're still, trying to make the perfect model, and, perfect is not fast. So that's my point of view on that.
That makes sense. Dr. Silverstein, I remember, because we've known each other for a bit, you started out with the Camden group. It was one of the earliest groups that tried to get two doctors to share information. What's your point of view? When are we going to get to accountable care?
It's interesting. I think that to answer that question, I think it's going to take some time before that really happens everywhere nationally. And part of the challenge we're facing here is actually in expectations. I think that if you look at what really is required for transformational change, it doesn't happen overnight. It takes actually decades. And if you look back in time, for example, something such as smoking, everybody knows now that smoking is bad for you. And what's interesting is if you look back at 1950, there was actually the first peer-reviewed publication that said, hey, smoking is going to kill you. However, it took 14 years before actually the CDC decided that they were going to publish these recommendations regarding that smoking was harmful to your health. So I think if it took the CDC 14 years to decide about that, it's going to take at least that long with value-based care delivery and perhaps a little bit longer. So I think depending on where you live, there are some places that it's happening today, but at the same time, we're going to be on a journey for a little while here and excited to keep pushing it forward.
Makes sense. Dr. Phansalkar, how do you think about this? You've been in academia, you were at Harvard. I think you're still on the faculty at Harvard. You were at the Brigham for a while. You've had that academic point of view, and then you worked your way into industry. Academicians often pose this question, right, with their students, and they do research to try to figure out when is this change going to happen to get true value-based care. What do you think?
So, David, I think there is no other way. I mean, the cost of healthcare is unsustainable. We know that, a third of what we spend on healthcare is waste. And all of these things align to tell us that things have to be done differently. And the reason Innovaccer is, so key to this transformation is there is no other way to do it other than combining technology and bringing that wealth of information back into the clinical workflow. Without understanding what is the high-risk cohort of patients that I need to focus on, without providing me the insights as I walk into taking care of the patient as to what I need to focus on, I'm really, selling myself short because I'm expecting the provider to give me better care at a lower cost, but I'm not enabling them in any way. And I think, that's kind of the thing that really sets us apart about what we do, this team does every day. Because we are enabling providers. We are enabling not just the philosophy of value-based care, but providing them all of the information and the tools to actually make that happen.
That's a great point of view, and it really gives us hope. However, as a patient myself, and having actually taken care of many members of my family with illness, as many of us have, my experience is that the care provider doesn't really so much think about my cost because they don't really understand what kind of coverage I have. Or to be honest, from a social determinant point of view, they don't even know how much money I make necessarily or where I live and some of my constraints. And we're so much talking about health equity. So these are all issues I think we need to sort of address with data. And we all talk about data. So I'd like to turn it over to Anil. Anil is an engineer first and a physician leader second. You've built from the ground up an analytics company to try to make better use of data. What's your prediction, thinking about it from the data standpoint, about when we're going to actually get the value?
Yeah, I think it's a great question, David. For years, I think we have been dealing with each and every single stakeholder having their pocket of or their silo of data that they use to make decisions. And I think with true value-based care, we're going to need to have all that come together with a trust and a transparent framework. I think one of the things that excites me about what we do is we focus on integrating the data into a single source of truth, so that all the different stakeholders, the health plan, those who purchase healthcare and pay for healthcare, and the providers themselves are all working from the same set of insights that can drive the very complex and in some cases simple arrangements that value-based care may take on. And I would argue that we have been seeing increases over time in value-based care happening, although we may not label it as the most mature models. Even this morning, there was a headline of the number of hospitals that got penalized for access readmissions. And one could argue that that is a way to sort of force driving value into the reimbursement model. All that is based on data. And if you look at that, hospitals are going to say, well, wait a minute, what data did you use for my Medicare patients? How did you calculate those numbers? So I think the first step is making sure that we're all sticking with the same definition of what we mean by readmissions, what we mean by the various clinical metrics that we're accountable to. I think it's all going to be around trust and transparency. Once you have that, coming up with business arrangements that can satisfy the 1 + 1 = 3, or the good for the patient, good for the plan, good for the purchasers, good for the provider, and good for the community is going to fall into play. And then you talked a little bit about social determinants of health. The challenging part of the way that the federal government has sort of pushed interoperability and our ability to share data is that we've started with these minimum data sets, this US core data for interoperability, and now we got some additional requirements for public health. But where are the requirements? Where are the standards? Where are the organizations coming together to say, how are we going to start sharing data that is non-traditional data? You mentioned how much patients make. Maybe there is a proxy for their consumer index or their credit scores that we would feel comfortable as a clinical community using to reach out to patients and engage with them. But I think a lot of this is going to be up to us and our peers in the industry to say, how do we create models so that we can exchange this data? Because I don't think we can wait for the government to push every possible standard. They're going to set the floor, and folks like us are going to set the bar when it comes to what kind of data do we really need to create that single view of the patient that's going to drive a very shared risk arrangement that's going to give us true value-based care for everyone.
And Anil, I would even add to that point to say that, unless the richness of that data is captured, right from enabling the EHRs to actually capture that data so the provider can actually go in and enter the information that's needed, right down to understanding what interventions work for whom, right? Not just restricting ourselves to a few variables that make us understand what intervention work, but enabling us to see, the real cohorts of patients. I think, yeah.
You said some magic words there, Shobha, and I want to push back on one thing that you said. You said that the EHRs have to collect this data. Let me argue something that I heard loud and clear from our future clients as well as our current clients at it just came back from the HMA Innovation Summit. And they kept talking about that the EHR is really a transactional system, the same thing that Mike has been teaching us as well. But they also talked about how there needs to be another layer of data that has all this information that we would consider to be non-traditional, because the last thing as a primary care doc, and even though I practice very, very part-time these days, I don't want all that data in front of me. What I really want is insights that are generated by people like us. What is this data telling us, and driving it back into the point of need so that I'm able to do that. So I would argue that we need to find a way to drive as much simplicity into the EHR as we possibly can, as opposed to putting more and more information in there. And folks like the folks on your team, Shobha, are going to have to figure out how are we going to drive those analytics and those rich insights to the person that needs it most. And maybe it's not me. Maybe it's the care manager or the care coordinator, or maybe it's the consumer themselves who's going to take an increasing role and responsibility. And would love to understand a little bit from Paul and Brian, what is the consumer's responsibility in all this? 82% of the hospitals got penalized for readmissions. What about the patient? What was their responsibility in doing all the right things so they don't get back and readmitted to the hospital? And what would our role as a analytics platform be in figuring all that out?
I'm so
So,
glad
Anil,
you
if I could-
corrected me
If I
there.
could add a story, if I could add a story to that to kind of illustrate it. One of our clients in Iowa, we began to see a real uptick in hospitalizations for hypoglycemic events in our diabetics. And when the data was presented to them that made that information clear what was happening, because the docs were fiddling with their insulin with that information. What was happening was it was happening in a few zip codes. There were poor parts of town, and it was happening at the end of a pay period. It was a population that was running out of food, right? And the data made it clear that that was the issue, right? And so stop fiddling with your insulin adjustments and begin to address the fact that you need to hook them up with a food bank. But to the point you're making about what's the patient's responsibility, in one of those practices, I followed a patient out to their car, and they had just, engaged with the doc and his team. And before they got in their car, Anil, they had a text which told them what just happened in the doctor's office, what medicine they were on, when they needed to follow up, where the closest food bank was, etc. So the information they needed to act on was there in an efficient, effective way. And with AI, it's sophisticated enough that you can look at your customer in healthcare the way Amazon looks at you as a shopper and understand that that information needs to be reinforced on Tuesday after 8 if you're a single woman with 3 kids, right? But that level of sophistication in taking what the doc needs to understand and also making that clear in a usable, effective way to the patient can really make a difference. I mean, that ability for the patient to have some clarity about what they need to do, and the physician has some clarity about what needs to be done to the patient. And I express that as, data is going to do for the doctor and the patient's mind what X-ray and imaging has done for our vision. It's just going to make it clear what you need to do. So I think
Paul,
that's
Paul, I just want to build on what you're saying there, which is fundamentally, we've got to make it easier for patients to be able to do the right thing for their care. And with the point that Anil was making, I think that when you really look at what's happened, EMRs, this is an amazing opportunity that we've digitized all the information. And so now all of it in theory is available so that people can better understand and act on it. But the unfortunate reality is that the EHRs are a transaction engine. And as a result of that, their goal and focus and their purpose has more been for billing and collecting and not really for the deep clinical insights and making it easy for people to do the right thing. I think that EHRs are foundational, and we have to start thinking now about how we extend beyond the EHR and make it easy and simple for physicians and other healthcare providers to be able to see what really needs to take place for patients so that, Paul, what you're referring to, then the patients can actually do those things. And I think it's incumbent upon all of us as an industry to do that. And it's interesting, when you look at the healthcare industry in aggregate, I'd almost suggest to you there's 2 segments. One segment is the traditional hospitals. All of them as a foundational system use their EHR. And then if you look at the entities that are really designed around managing risk, and their primary purpose is actually managing a population, they all have EHRs, but it's not their foundation or source system what patients and providers are logging into. So I think it's an interesting observation and something for us to ponder.
So let me kick off this into what this podcast series will focus on, the news, what's going on today. So one of the things that I answered when I had this interview by a journalist this morning, they asked me that question: when is value-based care going to come? And my answer was, I'm not quite sure. They were a little bit surprised by that answer. I said, I thought it was going to happen in 1999. I thought we were at the tipping point. And I brought up Malcolm Gladwell's book, Tipping Point, and shared with the journalists a little bit of the stories that Malcolm talks about, right? When did the sailing magnates, like the Dutch trading company, finally shipped over to steamboats? It all happened very quickly, even though they were around for a while, just like we're doing rehospitalization penalties today, little increments of value. Paul, I have a question. You've done a lot of work on the Hill, thinking about driving the patient-centered medical home, bringing together the right and the left, the Democrats, Republicans, thinking about legislation. Is the government going to help us get to the tipping point? And then I'd like to enter into all the points of view here, because I'm sure Mike, Anil, Brian, you're all going to have different points of view about this. Can the government bring us to the tipping point to move us in true value-based?
Interestingly, you should ask that question, David, as the language that allows that to happen is actually in the Affordable Care. Section 3021. The secretary can change the way they pay if the pilots under CMMI demonstrate value. And so, I mean, I think that that is happening. And to the tipping point phenomenon, I think that's how they look at it. Let's get the early adapters, let's support them, and then let's spread it. But we're already seeing that happening in many, many parts of the country. The example that I just said of a population of a hospital that was at risk for patients that were going to be hospitalized for hypoglycemia, changed how they looked at those patients, right? And that's helpful. I think we're up to somewhere close to 37% of now all Medicare patients being at risk for the system. So the pressure of the payment change is beginning to take effect. I think the pandemic probably sped a lot of this up, certainly in the ability to remote manage a population more effectively rather than bringing them into a hospital setting, right? But so there are mechanisms that are in place. And certainly, I know that the current administration wanted to press on that even further. And hopefully they'll have the support to do that with the legislation that might pass, hopefully in the next few days. I see they whittled it down to 1.78 billion instead of 3.5 billion. But again, I mean, that second leg of the stool that I talk about, payment change, as long as they pay for a button rather than the butt to keep out of the bed, it's going to be difficult, I mean, that it's if you're paid to do the wrong thing, it's really hard to change. Because so government has to pay to do the right thing.
And I think just this week, our friend Liz Fowler, who's now at the Center for Medicaid and Medicare Innovation, just released the new innovation strategy refresh plan. So we'll see. I mean, I think we all want to plow into that and get a sense of whether or not that will help move things along. Mike,
by the way, she wrote the language for CMMI. So if anybody understands what levers are there to pull, she does. So she's in the right place to help.
Mike, I'm curious on your point of view.
Oh boy, you knew this was going to be a good one. So first of all, ultimately, since we're talking about the government, we have to talk a little bit about politics. And I'm a raging libertarian. And so I don't think we need any more government control. I think those are Band-Aids trying to fix problems. We're a free market economy. We need to make sure that the consumer, and there has to be a piece of consumerism in healthcare, understands what the costs are, because inevitably they're paying for it one way or the other. And then let the supply and demand forces of a free market economy take effect to help go after that waste that Shobha talked about. And it works in every other industry, perhaps not defense, but why is it we can't understand what I mean? I'm as guilty as anybody. Aetna pays my bills. I don't know what things cost. I should be much more. I'm a naive consumer in this particular space. So you knew what you were going to get when you asked me the question. But I actually do believe, and we can enable it there too, because the costs are so hidden and kind of hidden behind what the payers pay, what the health system pays. I know my wife just had a minor surgery, and they go, "Oh no, we go to pay it." And she goes, "No, don't pay that. We're going to go talk. We're going to get a better price." I go, what am I buying a used car? Even used cars aren't like that today. Anyway, that's my somewhat off the cuff opinion.
It takes a team of different points of view, and that's why we have this team together. How about the rest of you?
Well, I'll take another stab at it. I think I'm somewhere in between. I'm a big believer in very precise regulation. As a as an innovator, an entrepreneur, I don't want there to be too many guardrails for the next innovator or the next group of folks who want to try something different. But at the same time, I think you have to have the incentives, as Paul mentioned, for people to do the right thing. So I think there are going to be three levers, and why the government's going to be important in our transition to value-based care. First, they're responsible for the vast majority in terms of dollars and lives between Medicaid and Medicare. So they have a fairly large sandbox to play in. The second is they are creating these the variety of reimbursement models and payment models. I'm sure Brian probably knows a heck of a lot more than I do about it. But if you are going to increasingly have capitated lives and as providers take on risk, then you have to give them the ability to try different things out to make that happen. And as direct contracting and as more Medicare lives go into Medicare Advantage, there's going to be significantly more, whether it will work or not remains to be seen, but significantly more, quote, value-based care activities going on. And I think the third one is a critical piece, which is near and dear to me, which is the government can start mandating how information moves back and forth between all the different entities. Consumerism, as Mike said, is going to be a powerful driver. The Cures Act, one of the primary roles of the Cures Act was to give patients and future patients access to their data. Once you do that, and once you make price transparency a critical piece, you start to equip consumers to be able to make the right decision. I still worry a little bit about the digital health literacy and the medical literacy. Do patients know what questions to ask? Do patients know whether the lowest cost is actually the best quality or the lowest quality? There's a lot of things that remain to be seen, but I think the government has got a very important role in removing barriers for innovation, and then taking a very consumer-directed aspect to it, because it's, after all, it's consumers who pay the taxes, and they deserve to have some transparency and trust in the way that they're getting their care.
You think Joe Bob's elixir is going to come back from the 1860s as being the cure-all, which is just a fancy branded bourbon?
Why not? If it's all value-based care, you can prescribe whatever you like, and as long as the patient gets good outcomes, why not?
Exactly.
Yeah. I think Anil and Mike, and we can. I think everyone can have different points of view on this, and I think even if you have a different point of view, I'm hearing everybody say the same thing, which is fundamentally, we all know that the government already is paying for a lot of healthcare. So regardless of whether we think that's a good thing or bad thing, it is. And so fundamentally, it will require the government making some changes to enable value-based care. And from my perspective, they have been making those changes. And if you look at, over the past decade, the number of lives that are in different value-based care programs, it's been steadily increasing. You look at the percentage of Medicare beneficiaries that are in Medicare Advantage, that number also has been steadily increasing. And so I think the government is taking appropriate and measured steps. And while some people perhaps are critical that they're going too fast, some are critical that they're going too slow, I think that one of the things that I think we've all been able to appreciate with the pandemic is that anytime you need to do something at scale, it's really complicated. And if you don't have the right systems and processes set up, then it can create a lot of chaos. And so I'm very hopeful that the government's going to continue in the journey that they have been, and promoting these types of payments such that it makes financial sense for people to invest in the infrastructure that will ultimately deliver the right care and the right outcomes.
Yeah, I would agree with all of that. I think it was great to, read the strategy document that came out of the CMMI and see an acknowledgement of, I think, everything that we've discussed here. What I also found really interesting was the recognition of the fact that a lot of our models have been primarily based on the Medicare population and don't necessarily generalize to the Medicaid population. And a recognition that, we need to bring in that population and create the right incentives, understand our safety net plans, especially with the landscape that we see where a lot of the hospitals are closing down. What does that mean for our safety net plans? So a recognition in the strategy document. I don't know what the next steps are for CMMI to actually operationalize that, but it was good to see an acknowledgement of it.
Does anybody have a sense of what those next steps will be? Because the document really walked through these general domains: driving accountable care, where we started, advancing health equity, which we got into a little bit with Anil, supporting innovation, and partnering to achieve transformation. Two things, Anil, that you're responsible for here. And then addressing affordability, which I think all of us touched on. But how can we actually get there? What are going to be the steps? What did people get from reading the report out from CMMI?
I mean, what I saw was a healthy amount of self-reflection as to what large pieces need to be in place. And I love the idea of being of what it is that we all need to do, but then allowing the innovators and the thinkers working between industry and health systems and health plans to figure out the how, and then playing that back and trying to create a sense of, if you're going to fail fast, and if it's going to make the kind of progress that one would want, how do you scale that up? Are there policy levers that can be changed to scale it? Are there technology barriers that folks like us can accelerate that can help scale it? But I love the idea of keeping it high level, so that folks like us around the table and our clients and colleagues can all get together and say, here's how we're going to do it, and playing that back periodically, I think is the important part. I think if the government steps, if regulators and policymakers spend too much time about the how, we go down a very dangerous road that we went down, and $35 billion into electronic health records. None of us are very happy with the way that's turned out. So I love the high level, and then allowing us to sort of pitch different concepts with our clients. That'd be awesome.
Sounds like that's the place that you and Mike would agree on. Free market.
You got that. Amen.
David,
I apologize. Excuse me, Dr. Grundy. I have to run, David. I gotta put a fishing pole in the water, fishing line in the water.
Gotcha. Enjoy Chime with all those CIOs there.
Yeah.
See ya.
Chime away.
Hi, Mike.
So what I was excited about in reading the change in systems in CMMI was they directly quoted from Section 3021. That's the one that the secretary has authority to change the way they pay. And they basically said, we've looked at 50 new payments over a period of 3 years with something like 30 million patients. And what we have found is that 5 of those payment models really make a difference and a really. And so we're going to focus our energy and attention from what we learned on driving those changes. And I think beginning to really focus on beyond 1,000 flowers blooming onto what really worked, using the data that they've acquired over that time. I think he has a chance to make a difference, and this is just a week old. So I'm excited, as you are, in Liz really being focused on really streamlining, ensuring equity, and streamlining that portfolio of how they pay.
Paul, I think you highlighted something that's I think important to put in perspective, which is that anytime you're going to try something new, it's not always going to work. And that's where, if you think about really what's happened, there's, as you articulated, there's been a ton of things that have been tried, and most of them didn't work. Guess what? I view that as a success, because now we've eliminated things, and at the same time, we've narrowed down. The other thing that I think that's interesting with healthcare, you do have this whole notion of fail fast. And I think that's absolutely true in anything. But again, it gets back to how you define that time horizon. If you think about how long it takes for interventions to actually work in populations, I'd suggest a year, which is the standard contract length, is not long enough. And so fundamentally, we need to move to a longer length of contracting. And in doing so, anytime we're going to do different type of experiments, they're just going to take a little bit longer before we really can see which things work and don't work and drive the incentives. And I think it's a very healthy process that CMMI is going through right now in terms of narrowing the portfolio and focusing in. And I think there's going to be a lot of benefit for the American people and the healthcare system in doing so.
Well, Brian, I completely agree with the time horizon, but I'll make one quick comment that something that I've been hearing from a lot of folks is that some of the time horizons that we think about, especially with Medicare data, is all artificial. It's how fast the data can be aggregated and analyzed. And I know you think about the payment year and think about prospective and concurrent and all that. But I think as we get better and better at data management, and we're certainly making significant strides in that, one would imagine that for certain metrics, you don't need to wait a year. Maybe you only need to wait a few months for certain things to see whether, A/B testing, we try it one way and we see that from a process point of view, we're making a difference almost immediately. And then for certain clinical outcomes and maybe some high-level cost indicators might need to be longer. But I think the idea that a one-size-fits-all, where the old days of looking at a 1 year of Medicare, claims data that are crunched by data scientists sitting in Shobha's shop, I think those days are going to be gone, where we're going to need to do continuous data analysis, continuous signals, using AI, machine learning to figure out what are some patterns that we can propagate, and be able to very transparently start communicating those insights, so that we can do this we can iterate much more quickly in certain areas, and then take the time we really need in other areas. So I don't disagree with you. I just think that for certain things we might need to go faster, and we, for the first time, have a data activation platform that can actually start to look at this data much more quickly, if our federal partners and others can serve that data fast enough.
Absolutely, Anil. You're not disagreeing. I think we're agreeing. And I think what I'm thinking about, though, is just the operational implications. And I agree with you. That's a great point, that with the data available faster and quicker, we could see results faster. I'm just thinking about, from a practical point of view, let's say we have a patient who has congestive heart failure, and we make some changes to their diet. It's going to take months before they really adopt those changes and monitor them and see the results and impact of that. And you think about other interventions in terms of people being able to be more compliant with their medications, people that have a whole host of other things that they're doing for their healthcare, then it just sometimes takes a little bit to scale up to get the people and the processes in place. But I'm right there with you, that if we had better information, we could act faster. Boy, that's amazing. And I think that's where we could really start to see some benefits.
Yeah, and I'll just, heart failure is a perfect example. Your point, did dietary changes make a difference? I'm still stuck sometimes in my primary care practice, and I practice very part-time now. But when I was practicing more regularly, it was all an inner city population in Cleveland, and it was simply, did they even go for the dietary visit? Did they even have that one process metric satisfied? And so before they can even make changes, did we get them to the place where they needed to go? And so on. So I think there's going to be a lot of room for a lot of different experimentation in this space, and I do believe having a unified set of data is going to make or break how fast we can iterate on what's working and what's not working.
Yeah, absolutely. And I think just extending that, having a patient go to a dietitian, at that point in time, we've lost. So what we really need to do is send the dietitian into the patient's home, have them go shopping with the patient, and then help them figure out how to prepare the meals. And that sounds like a really extreme statement. It's like, oh my gosh, think about the cost with that. But at the same time, think about how common is it that patients with congestive heart failure end up in the hospital. And I could tell you, almost every patient with congestive heart failure has been told, follow a heart-healthy diet. However, they don't do it. And why don't they do it? Well, some might say, oh, they don't have the willpower, they're non-compliant. I'd suggest to you that's probably true in some cases, but in a lot of cases, it's a knowledge gap. They just don't know. And the systems and processes aren't set up today to be able to facilitate and enable that to occur. And that's what's so exciting about new payment models and data platforms, is that if we could put these things in place at scale, get the right incentives in place, you actually can really materially impact health on a large scale basis.
Brian, I completely agree with you. I think, in addition to the clinical outcomes, which, as you said, would take a while for us to see what's working or not, I feel like, there's a blind spot in being able to understand the patient's experience. And I know I've had these conversations with Dr. Nace before, I feel like we do such a limited job in terms of understanding the patient's journey in the healthcare continuum and what matters to them. And that's the one change, that I would love to see. And I think there's reference to that in the strategy document as well, patient-related outcome measures. The more we can focus on what matters to the patient, the more we can actually, make a difference. Because at the end of the day, they are at the center of that healthcare journey. And they are the ones, when Anil prescribes them either a medication or that nutritional intervention, they're going to make a decided opinion of whether they're going to go forward with that or not. So anything that we can do to arm the patient as well as understand their experience is pivotal.
I think it's going to be critical, though, Shobha, that we not do a one-size-fits-all. We cannot presume to know what each and every patient finds to be the most important part of their healthcare journey. So I think one of the challenges that we've had for a long time, I've been doing quality measurement for health systems, for other companies for a while now, is that we typically are measuring what we can measure, and we're not really measuring what matters. So as we get more sophisticated about our ability to collect data, again, not asking doctors to collect this data, we need to be smart about how we can perhaps extract data from the interactions that they already have with their patients and look at what drives their behavior change and what delights them. We got to help those folks who are putting quality metrics in front of healthcare systems to be much more broad in the way that they define patient experience, because you don't want to drive patient experience because they had a brighter waiting room when they've got a higher readmission rate for heart failure. Those kinds of things are what gives docs in general that I speak to a lot of skepticism about what we're actually measuring. So if we can start to get real patient experience metrics that drive the kind of behavior change and the kind of delight that patients need, I think that that's great. We definitely need that. But the government may not be the ones to tell us what to measure. We need to start working with consumer groups and staying one or two steps ahead of where the regulators are in terms of what's mandated.
It's a great point, Anil. I think the nice part about, for those of us who work in healthcare, is the opportunity. There's a long way to go around the patient experience to get to delight. So I think we can all agree upon that. Well, listen, this has been a great discussion. What an awesome team. I just feel honored to be able to have you all together and hear these different points of view. It does take the different points of view in a team, and you're an effective team. And clearly, this is the sort of respect we want to see in healthcare to get the kind of collaboration we want. For our audience, that's all the time we have for today. Thank you very much for listening, and thanks to all the panelists for taking the time to chat. For our listeners, this is the inaugural event of this blog. So going forward, we will take each week's news from a variety of different sources and plow into one, just like we did today with CMS's Innovation Strategy Refresh. Also, check your notes on the system, because we will include a link to the CMS document where we've covered a lot of the points in that document, those 5 bullet points of driving accountable care, when will we get there, advancing health equity, the social determinants of health, supporting innovation, addressing affordability. Notice they didn't say fix, they said addressing affordability, so cost will be an issue, and partnering to achieve transformation, because that's really the end goal. So for more information, check your notes, and for more information about Innovaccer, just go to our website, innovaccer.com.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovaccer, the health cloud company. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate your transformation and build the future of health on the Innovaccer Health Cloud. For more information, please visit innovaccer.com.